This meeting is now being recorded.
Well, welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give you an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speaker for this evening, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna, who's on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with hypermobile EDS in 2008, the same year my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've been a sponsor for these conferences for the last 5 years, and we've helped to form over 110 support groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We typically meet monthly at 7:30 p.m. Eastern Daylight Time. All of the programs are free. The meeting announcements and wherever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free guide on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. Proceeds from the store and donations to our nonprofit organization help fund our programs. Please visit our store and check out the helpful products that we offer. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
Our next webinar will be on June 20th. Dr. Sood and Dr. Kovacic will be discussing gastrointestinal motility disorders and cyclicity for Q&A after the presentation. Add your questions at any time by clicking on the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Dr. Gisela Chelimsky, and she is a professor of pediatrics at the Medical College of Wisconsin and was previously professor of pediatrics and neurology at Case Western Reserve University School of Medicine in Cleveland, Ohio, where she served as director of the Pediatric Autonomic Disorders Program at Rainbow Babies and Children's Hospital at University Hospitals of Cleveland. She graduated from medical school at the University of Buenos Aires, Argentina, and completed residency in pediatrics and her pediatric gastroenterology fellowship at Rainbow Babies and Children's Hospital. She joined the faculty at Case Western in 1996 and rose to the rank of professor in 2011. She is also board certified in autonomic disorders. Her work is focused on functional gastrointestinal disorders and understanding the interrelations between the brain-gut axis and the comorbidities that come with these disorders. Dr. Chelimsky has published more than 50 original articles, contributed to 17 books, and made multiple presentations at regional, national, and international meetings. And it is my great pleasure to introduce Dr. Chelimsky, and we really appreciate you sharing your time with us and your expertise. I'm going to go ahead and turn the microphone over to you for your presentation.
Thank you so much for your introduction, and thank you for everybody that is listening to this presentation tonight, or whatever hour is in your part of the world. A few disclosures here. Any medications that we're going to discuss today is going to be used off-label, and most of my work is supported by an Advancing Healthcare Wisconsin grant. What I would like to accomplish tonight is to review a little bit the new criteria that has been developed for hypermobility EDS, and I know that most of the audience may be aware of this, but I think that it has some implications to understanding the previous studies that were done that were not following the new criteria. Also, understand the gastrointestinal symptoms that come associated with hypermobility EDS, and comprehend the association of hypermobility EDS and orthostatic symptoms. So just as a quick review, and I don't want to spend too much time here, neither did I put all the types of EDS here, but as you can see in this slide, I put the first 5. Most of the EDS, we understand the genetics, we understand the protein that produces the disorder, but the talk tonight is really a focus on the hypermobile EDS, which is now the new terminology. We don't use anymore EDS3 or benign joint hypermobility. And I think that it's important to remember that we do not know the genetic mutation or abnormality that is associated with hypermobile EDS or the protein that comes involved with this. So this new classification, and I was part of the guidelines writing, really has made the criteria to define hypermobility EDS much more strict. And we need to fulfill several criteria to really get the diagnosis. Even the Byton score, there is more strict guidelines now. For example, in prepubertal children and teenagers, we need a Byton score greater than 6. Then in pubertal men is 5, and in women up to age 50. And after age 50, we all know we are getting stiffer as we age. We just need a Byton of 4. And again, I point this out because many of the pediatric studies are done with Bytons of 4, or even some adult studies. So I just think that that's important to understand that it may change the data that we obtain in the future when we do research. I think that everybody is familiar with the Byton scores. And like my geneticists in our group would always say, Gisela, if you need to force the thumb to touch the forearm, this is not hypermobility. It has to happen very, very easy. And even in this case, we could argue that this is not correct because there should be almost no space here when you get the thumb against the forearm. If you need to do 20 minutes of yoga before you can touch the floor, you may not have at least a point for a Byton here. And when we look at the right angle here, I think it's very important that we are supporting the hand, so we are not flexing the hand back and then over-diagnosing the hypermobility. And also remember that the hyperextension of the arm in females and males is different. Females in general need to have more than a 10-degree, while males don't need that. And here we go to the big, complex definition that this new guidelines now presents to us. So we need to have 2 or more criteria of these 3 groups. So the first group talks about the skin, talks about the skin hyperextensibility. Now we know how much we measure that skin, 1.5 centimeters. It really describes in detail the stria. It can be because you lost weight or you had pregnancy. It talks about rectal and pelvic floor prolapse. And some of the other things were very clear before, but I just want to say that we need 5 of these criteria or more to fulfill one of the next criteria for hypermobility EDS. Also, we go in much more detail about the musculoskeletal complications. Here we need at least 1. We include now musculoskeletal pain in 2 or more limbs. It doesn't need necessarily to be joint pains anymore, or can be also chronic widespread pain for more than 3 months. We have some of the older ones, like recurrent joint dislocations, trunk joint instability, which have not changed from the previous ones. And as it was in the older criteria, the positive family history is also important. So now let's focus, having finished this background, on the gastrointestinal dysfunction that comes associated with hypermobility EDS. So most of the studies in adults come from the group of Kasim Aziz in England. And they did several studies where they got new patients that were coming to the GI office that had no previous diagnosis of, in this case, they call it joint hypermobility syndrome because it was before the new guidelines. And they look at the patients that came and they looked if they had joint hypermobility or no joint hypermobility. And they also took a group and they sent them to the rheumatologist because they're gastroenterologists like me, and they just wanted to be sure that the rheumatologist felt that this group of GI patients had this hypermobility. So then, when we look at the data, we have a group that doesn't have joint hypermobility but has GI symptoms, a group that has joint hypermobility and GI symptoms, and then the group that has joint hypermobility and GI symptoms but was diagnosed also or confirmed by the rheumatologist. What they found is that 1/3 of patients that walk into the GI clinic had undiagnosed joint hypermobility syndrome. And I think that this is fascinating. This is huge. That means that 30% of the patients that we see in GI have this disorder. And again, I want to caution, we didn't probably hear the whole criteria that we use today for hypermobility EDS was probably not applied. I think that they focus more on joint pain dislocation and Beighton scores. And the main GI symptoms that they found in this group of patients was upper gastrointestinal symptoms. With that, I mean increased reflux, the feeling of fullness when they eat, what we call dyspepsia symptoms. Next, I want to focus on this table at the bottom. We can see that patients that have joint hypermobility and GI symptoms tended to have more fibromyalgia than the ones that had GI symptoms and no joint hypermobility. When we compared it to the ones diagnosed by rheumatology, that number goes even higher. So this difference here was significant, but this difference here was even more significant. So the assumption I'm making here is that obviously the ones that the rheumatologist felt that had joint hypermobility probably were much more involved than the other ones. When we look at urinary symptoms, we see that the patients that had had no joint hypermobility with GI symptoms didn't have any urinary symptoms. We see more urinary symptoms in the GI group with hypermobility, and again, if the rheumatologist made the diagnosis of joint hypermobility, that prevalence of urinary symptoms increases. Orthostatic intolerance, which means that people develop symptoms of dizziness, lightheadedness, nausea, sometimes headaches in the upright position, was also higher in the GI group with hypermobility than the GI group without hypermobility, but again, much more significant in the group that was diagnosed by the rheumatologist. The next line is very interesting because none in any of these groups had syncope. When we get to the second half of the talk today, we are going to see that some of the other studies looking at autonomic dysfunction finds that patients with hypermobility tend to have more syncope. In vasomotor problems was much more common in the group that had the diagnosis of hypermobility done by the rheumatologist. Then the same group did a very interesting study. Now they took new patients that came to the GI office. This is adult clinic. They didn't know what they were going to have, if they were going to have an organic disorder like Crohn's disease, celiac disease, or if they're going to end with a functional gastrointestinal disorder. And just as a quick review, a functional gastrointestinal disorder is a disorder that we can't find on routine tests any abnormality, like the scopes are normal, the blood tests are normal, and just for the audience, those are not psychological disorders. Just means that we physicians haven't understood yet the pathophysiology. But then 3 or 4 months later, they looked at what was the diagnosis, and then they divided them based if they ended having a functional gastrointestinal disorder or if they ended having an organic disorder. And interestingly, the two groups divided quite evenly. And what they found is that the group that ended having a functional gastrointestinal disorder had much more hypermobility than the group that ended with an organic disorder. For example, the Crohn's disease. They also found that if you had hypermobility, you usually had more upper gastrointestinal symptoms and more postprandial distress symptoms. That means that you eat, you feel full, you feel nauseous, you have upper belly discomfort. They also found that if you had a functional gastrointestinal disorder with joint hypermobility, usually that group had more chronic pain, more fibromyalgia, more somatization score, more urinary symptoms, and I think that it's quite obvious that if you have all these things, your quality of life was much worse. So I think that the point that we can make here is that functional gastrointestinal disorders are associated with benign joint hypermobility, and that the association of functional gastrointestinal disorders with benign joint hypermobility comes with more symptoms than just the gastrointestinal symptoms. It comes with general as pain, fibromyalgia, urinary symptoms, and worse quality of life. What other GI symptoms are associated with joint hypermobility? So if we look at different papers, and I didn't summarize all of them, but I summarized the biggest series, we see that abdominal pain is present in 56% of patients with hypermobility EDS. Nausea is very common. Constipation, heartburn, irritable bowel syndrome, and diarrhea. And I have to say, in my clinical practice, I see a lot of upper abdominal pain, lots of nausea associated with hypermobility, EDS, and constipation. Now, with all this amount of upper GI symptoms, what is happening? Is it that they have delayed gastric emptying? Is it that the food that gets into the stomach stays there for a long time? And again, these are two papers that I review, two series, and we can see that in one, there were 76 patients with different hypermobility disorders. They were not all necessarily hypermobility EDS, and they found that the gastric emptying was abnormal in 17. But in half of them, it was accelerated, and only in 9 was delayed. And just as a comment, it's very interesting that the symptoms of accelerated gastric emptying are pretty much the same as the symptoms of delayed gastric emptying. And I know that that sounds surprising, but there are many publications that says that the two symptoms really overlap. Then the other series, there were 63 patients, and 17 had again abnormal gastric emptying, but only 12 out of 17 had delayed gastric emptying. So in some way, the conclusion is that delayed gastric emptying is not common in EDS. Now, just because it's not common, would I not investigate it? Absolutely not. If a patient comes to me with a lot of nausea after eating, the feeling that the food is sitting there 3 hours after a meal, I would probably order a gastric emptying test. But just as a knowledge, it's not a common association. So what do we know about the data in pediatrics? And I have to say there is very, very little data in pediatrics and hypermobility. We do know that children that have hypermobility EDS tend to be more constipated. Constipation is more common in boys with hypermobility EDS, and that children with hypermobility EDS have GI complaints in 54%. And 56% of adolescents with complex functional gastrointestinal disorders are found to have hypermobility EDS. This is data from our group. This is data that we presented 2 years ago that we did with Dr. Kovacic, which is going to be your speaker next time. And again, we were looking mainly at Beighton scores, and we can see that about 65% of the patients that I see in my patient population, these are not healthy kids. These are kids with what we call in this time chronic overlapping pain conditions that have dizziness, postural tachycardia syndrome, migraine headaches, functional GI disorders, chronic fatigue, that about 55% will have a Beighton score of 4 or higher. And because we didn't have controls, we use controls from the general population, and we see that there is a significant higher prevalence of hypermobility in children that have functional GI disorders. And as we showed in the previous series, we were not the only ones to report that. Pacey reported that the gastrointestinal symptoms are present in 54% of children that have joint hypermobility. So again, in adults, joint hypermobility seems to be associated more with functional gastrointestinal disorders, and probably in GI and in pediatrics, we have similar findings. So what are the interventions that are suggested? And these are really very general. Some people suggest nutritional supplementation. Some people suggest FODMAP diet. That is a diet where you decrease a lot of the fructose, oligosaccharides, disaccharides, monoamines, and polyols. And what probably happens is that you decrease the sugars that produce fermentation. We know that this is being used, this FODMAP diet, in patients with IBS, and we know that there is a huge overlap of IBS and hypermobility EDS Therefore, probably there is evidence that this diet may help. Just as a word of caution, the FODMAP diet is a very difficult diet. It's a very restricted diet. And I think that nobody should start a FODMAP diet without a physician and a dietitian following them to avoid a lot of deficiencies in the diet of micronutrients and so on. Because constipation is so common in EDS, it's important to manage the constipation aggressively. We know that many times when you are constipated and you are full of stool, your nausea gets worse, your upper GI symptoms get worse. So it's crucial to look at the entire patient and the treatment. And for many reasons, we preach to never use narcotics for the chronic pain for many reasons. One is that narcotics in chronic pain doesn't help. Second is that narcotics will worsen the constipation. So I think that the use of narcotics in EDS hypermobility should never be in the equation. I have patients that then said, oh, Dr. Chelimsky, I'm having an appendectomy. Can I have narcotics? Absolutely. When you're going to have an acute event or somebody is removing your wisdom tooth, you can use narcotics for that. But wean the narcotics off as soon as you can, because we know that narcotics really increases chronic pain and this hyperalgesia that we find so often associated to these disorders. So now let's switch a little bit to the hypermobility EDS and autonomic disorders. And I love to see that Peter Rowe was already talking about this in 1999, so quite a few years ago. Peter Rowe reported the association of the orthostatic intolerance, the chronic fatigue, and EDS in adolescents. He reported 12 subjects, 11 of them were females, with a mean age of 15 years. 5 of them had at least 3 syncopal episodes, a little bit different from the study that I showed you before, and 7 of them had lightheadedness without necessarily fainting. And all of them met the criteria for hypermobility EDS or classic EDS. So people have been reporting this association for quite a few years at this point. This is a study that comes from the group of Blair Grapp in Toledo, where he now compared patients that had postural tachycardia syndrome, as you can see here at the top, with joint hypermobility, and patients that had POTS but didn't have joint hypermobility. We can see that there was a little bit of difference in the age group. There was a significant difference here. The POTS group without joint hypermobility tended to be a little bit older. There was similar distribution of females and males, similar racial distribution, but there are a few things here that there are a little bit difference between the two groups. Sorry, I thought that. One is the migraine. We see that the patients that have POTS with hypermobility have a lot more migraine than the patients that have POTS without hypermobility. When we look at the trigger, was it a trigger that predisposed them to this? Overall, there was no significant difference, but there was a tendency towards a significant difference here in starting with a viral illness. And we see that the viral illness seems to trigger the POTS in the patients that did not have joint hypermobility. And in some way that makes sense, because probably hypermobility in itself is a predisposing factor, while patients that don't have hypermobility may need a trigger to produce the POTS. The other thing that was significantly different between the two groups was the prevalence of syncope. Patients that had POTS with joint hypermobility tended to have more syncope than the patients that had POTS without joint hypermobility. Interestingly, the fatigue was the same in the two groups. The palpitations when they were upright was similar in the two groups. And the dizziness and feeling that I'm going to faint was similar in the two groups. So, how do we relate these two? This is another study that was done in adults where they took patients that had Byton greater than 4. And again, more women than men. They were adults with an age of 18 to 69. And they compared it to healthy individuals with a Byton of less than 2. Again, a majority of women, the same age in the two groups. And they found that the people that had a Byton greater than 4, again, had more syncope, more pre-syncope, more palpitations, more the feeling of chest discomfort that comes associated with orthostatic intolerance, more fatigue, and even heat intolerance. And when they compared the tilt table in the two groups, they found that the group that had the hypermobility also had more positive tilt tests. With that, we mean that either had orthostatic hypotension, postural tachycardia syndrome, or orthostatic intolerance, which means that you develop symptoms when you are in the upright position. And if we look here at the bottom of the slide, we see that 78% of the individuals with benign joint hypermobility had a positive tilt test versus only 10% of the healthy controls. Now, I'm going to talk a little bit about our data in our group. You know, we run one of the few pediatric autonomic centers in the country, so we tilt a lot of patients, and we have referrals locally and nationally for patients with what now NIH calls chronic overlapping pain conditions. So we looked at the patients and we looked at the distribution of our Byton scores, and I don't think that this is surprising, but the vast majority of our patients had a Byton score of the abnormal ones around 4. Obviously, we had many that had no hypermobility. So just taking this into account as the background to our patient population, we then compared our patients that have chronic overlapping pain conditions, and we looked at those that met tilt table criteria of POTS, and you see them here in black, the black columns, and those that did not meet the criteria for POTS, and this is children, I don't know if I said that. And we looked at the comorbidities of having POTS and not having POTS. And the one I want to focus today here is the joint hypermobility. We did not find that there was such a big difference in the prevalence of POTS if you had joint hypermobility and if you didn't have joint hypermobility. But here is where I want to emphasize why I presented the first few slides with the new criteria. We were just looking mainly at Byton and joint pains. We were not applying the full criteria for a hypermobility EDS. Maybe these numbers would look very different if we would apply the new criteria, which is much more strict. Just as a side point, if you look at the slide, you see that POTS in itself is not a driver of the comorbidities in patients in general. Having POTS or not having POTS show the same prevalence of fatigue, sleep problems, dizziness, syncope, migraines, chronic nausea, fibromyalgia, hypermobility, or functional gastrointestinal disorders. So my personal feeling is that POTS is not the driver of a lot of the comorbidities that we see in many patients. Now, our numbers are different from what's reported in the literature because we are not comparing to healthy controls. We are comparing patients with this constellation of symptoms of chronic pain or fatigue to patients with the similar constellation of symptoms, and trying to differentiate if hypermobility is different in two groups. So we did that study, and we had taken the Byton of 4 And then I said, okay, well, maybe we didn't see a difference because we were really not that strict. We didn't look at dislocation. We didn't look at all the other criteria. So we went back and we looked at our data, and we were much more strict. Now we divided population with bite on 6 or higher, but had to have either dislocations or arthralgias or have been diagnosed with a hypermobility EDS by our genetic team. And we compared those, again, to my patients with this chronic overlapping pain conditions that had a Beighton score less than 2. So we really wanted to be sure that we were dividing the two groups very clearly and not just having this middle-of-the-road Beighton of 4. And interestingly, I will walk you through the slide, but I think it's quite easy. This is the benign joint hypermobility. This is the no benign joint hypermobility, and this is the p-value. There was the same prevalence of postural tachycardia syndrome. To be honest, I was surprised how little. Syncope during tilt, we had a lot of syncope. Half of the patients in each group, or a little bit more than half, fainted. But there was no difference between having hypermobility or not having hypermobility. Orthostatic intolerance, which we define as having symptoms when you are upright in the tilt table test, but not meeting criteria for orthostatic hypotension or orthostatic or syncope or postural tachycardia. And again, there was no difference. Interestingly, orthostatic hypotension, which is very uncommon in pediatrics, and usually, in my way of thinking, when a child has orthostatic hypotension, they have a more severe autonomic disorder. That was even more prevalent, not significantly, but more prevalent in the group without joint hypermobility. We look at the baseline heart rate. Okay, are the patients with hypermobility because of the connective tissue and the vessel laxity? Perhaps they have more tachycardia because there was no difference in the heart rate at baseline, and neither was it a difference in the heart rate when they were standing in the tilt table in the first 10 minutes. I mean, there was an increase, which was expected, but the increase was very similar between the two groups. So in our experience, having hypermobility does not increase your prevalence of autonomic disorders. And again, our numbers may be different because we are not comparing to healthy control. I'm trying to figure out, in my patients that come with this constellation of millions of symptoms, who is or what is the driver? Is the hypermobility the driver? Is the postural tachycardia the driver? Is there something driving these disorders? And at least in our data, I have to say that neither postural tachycardia or benign joint hypermobility are the drivers to having this chronic overlapping pain condition, which in the past were called functional somatic disorders or unexplained pain syndromes. So we don't know what's the driver. We know that all these symptoms and signs and findings coexist, but we don't know who is responsible of them. And the very last thing I want to touch just briefly is what I always get asked by patients. Okay, Gisela, do they have mast cell activation disorder? Is this the driver? And there has been a link, again, between mast cell activation disorders, EDS, much more or mainly the hypermobility EDS. And some people talk about a new group that has these three disorders where the POTS, the mast cell activation, and the EDS come together. I think that we have very little data on MCAT at this point. We know that some of them have increased number of mast cells, some have increased activity of mast cells, or some have both, but we don't have yet good consensus definition. The proposed criteria for diagnosis mast cell activation disorders at this point includes that you have to have symptoms or signs of a mast cell mediator release that affects at least two organ systems. For example, in the skin, it can be flushing, urticaria, itchiness, angioedema. In the cardiovascular, it could be hypotension, and here is where your POTS comes into picture. You can have asthma-like symptoms. In GI, we see the diarrhea, the cramping, the bloating. When we think about ear, nose, and throat, we see the itchy nose, the itching eyes, or you can have just anaphylaxia. To have the criteria, you also need to have, or to have MCAT, you need to have laboratory evidence that there is release of mast cell mediators. And you have to respond to the current therapy. And I put a list of the therapy that has been proposed at this point. In the different tests, I think that we all struggle in clinic or when patients ask us, what do we use as tests to diagnose mast cell activation disorder? So the current suggestion is that the tryptase has to be elevated at baseline, or after you have an episode, you have to have a 20% increase plus 2 nanograms per ml above the baseline. You can also have an elevated N-methylhistamine in a collection of 24-hour urine. Some prostaglandins are elevated in the urine. Your heparin may be elevated, the chromogranin, or if you find some characteristic finding when you do a biopsy of the affected tissue. There was a report just last year of 35 families that had increased basal tryptase, hypermobility EDS, autonomic issues, chronic pain, functional gastrointestinal disorders, cutaneous flushing, so they were turning red and feeling hot, and itching. And what they found, which I thought that was fascinating, is when they did genetic testing, they found that they had an allele that encodes for 3 copies of the alpha tryptase. And if patients had these 3 copies, they had higher basal tryptase and more symptoms than those that had 2 copies. So the question comes, is this a different group of diagnosis? Do we need to start looking into this? And I don't have the answer, but I think that there are a lot of unknowns in this area. I check often tryptase in my patients, and I think that so far I have only found 1 patient with an elevated tryptase. Do I treat people empirically without necessarily having abnormal labs? Yes. And sometimes patients would say that a lot of, like if I give cromolyn, a lot of the gastrointestinal symptoms improve. So I think that this is an area that needs a lot more research. So, in conclusion, hypermobility EDS is associated with functional gastrointestinal disorders. There is an association also of hypermobility EDS and orthostatic symptoms. But we are not sure yet if this overlap of functional gastrointestinal disorders, orthostatic symptoms, and hypermobility EDS is part of EDS, or is this part of this chronic overlapping pain conditions that now the NIH is really putting a lot of emphasis for us to further understand? And many questions come from this. Are the studies that we did until now, would we get the same results if we use the new criteria for hypermobility EDS? I think that we need to repeat a lot of studies. We need to have much more studies in pediatrics. We need to understand what's the prevalence of hypermobility EDS, orthostatic intolerance, and POTS. We need to understand if we apply the new criteria for hypermobility in EDS, which % of the population has it? And then, is this an association? Putting the 3 diagnoses together? Is it causation? We don't know that. I think that there is a lot to learn here. And this is all I have now, and I would like to open it up for questions.
Okay, great.
We have some questions that the live attendees are starting to put into the Q&A box. If you can go to the top of the screen, you should be able to.
Okay, I'm going to answer the questions in a general aspect. So sometimes there was a question related to having a lot of GI symptoms after eating, mainly in the evening, and if that could be related to mast cell activation, or if this could be related to craniocervical instability. And I'm first going to say I'm not a neurologist, so I'm going to leave the craniocervical instability aside. If the complaint here seems to be mood issues. I think that depends on what are the symptoms. I mean, if we eat a meal and we develop bloating, diarrhea, flushing, maybe itchy nose, I think that mast cells should be in the differential. Now, without the itchy nose and without maybe the flushing, although the flushing can be there too, I think that maybe it's important to get a gastric emptying. Not only for delayed gastric emptying, but also for accelerated gastric emptying. If somebody has accelerated gastric emptying, it's what we call dumping syndrome, you can get a lot of cold sweats, feeling clammy, feeling nauseous, even feeling kind of dizzy and queasy after eating. So I think that could be useful to look there too. I think that always trying an empirical treatment with cromolyn and an H1, H2 blocker is benign enough, and I think that that's easy to do and see if the patient improves. We have noticed in our practice that sometimes instead of going with 100 milligrams of cromolyn, we do 200 cromolyn. That we have tried it in a few patients that didn't respond to 100, and then when we doubled the dose, they had some response. There is a comment from that person saying that it's hard to find physicians that don't think it's psychosomatic. I agree with you. I do agree with you, and I think that part of what we need to do is education, education, and education. Next one, patient with EDS and dysautonomia has severe abdominal pain and weight loss. What should we evaluate at least? So I think it's important. I think that I would look for delayed gastric emptying. Obviously, having EDS and having dysautonomia does not mean that you cannot have other diagnoses unrelated to that. When I see significant weight loss and belly pain, I think that it's important to rule out inflammatory disorders like a Crohn's disease or something like that, or a celiac disease. You know, I think that sometimes, and it happens to me in the practice too, I'm so used to see chronic overlapping pain conditions that I forget that I'm a general gastroenterologist, and that general GI disorders can happen to my patients too. So I think that the significant weight loss, to me, is always an important red flag. And I think that that person needs a GI evaluation by a gastroenterologist to rule out Crohn's disease, rule out celiac disease, delayed gastric emptying, just be sure we are not missing something. Once we know that we are not missing anything of organic GI disorder, then the question is, did she develop an SMA disorder? When you lose a lot of weight, then what happens is that sometimes your fat patch between the aorta and the superior mesenteric artery disappears, and we compress the duodenum, and you can present either with nausea or vomiting, or sometimes you just stop eating because you feel so sick. So I think that it's important to rule out SMA syndrome. Okay. Any suggestions for those with daily headache who seem to need to take daily aspirin, Excedrin, migraines, but also have a diagnosis of gastritis. Again, I am not a neurologist, but I practice enough with my neurologist next to me, who is my husband. And I've learned enough from working with a neurologist. Daily nonsteroidals for the treatment of headache is no good. When you treat headaches with nonsteroidals more than once a week, you generate a headache due to a nonsteroidal. And that I know was not the question. The question was, do we worry about gastritis? Yes, we do. But a headache should not be treated with daily nonsteroidals. So that's the first point. If somebody has daily headaches or daily migraines, like the question is here, I think that you need to find a prophylactic medication for the migraine that gets you out of the nonsteroidals. And once again, using narcotics is a no-no. No chronic pain should be ever treated with a narcotic. But we have a lot of medications from the family of the tricyclic antidepressants to the topiramate to gabapentin, different medications that depends on the patient can be used for the migraine. So I think it's important to find a neurologist or a pain doctor that handles those migraines in a better way. Any special cautions for inner manometry study for EDS patients? I think that the times that we really worry when we do invasive studies is mainly with vascular EDS. I don't think that there is any concern with inner manometry for hypermobility EDS or even classic EDS. Sometimes the colon is so redundant that the balloon has to be inflated. I don't know if this question is related to anorectal manometry or colonic motility, so I will answer it both. For the colonic motility, sometimes when the patients have a very redundant colon because of the connective tissue, it's harder to place the probe because the colon has 20 million loops. And for the anorectal manometry, you may need to inflate the balloon to higher volumes if the colon is very distended before you can say if the patient feels the balloon or does not feel the balloon. Questions about complex regional pain, GI, and EDS. Not that I'm aware, but please don't quote me on that. I'm not a complex regional pain specialist. We do see a lot of our patients with complex regional pain, although I don't treat it. We do see them because of the overlap with all the autonomic issues. But I am personally not, I don't have the knowledge to answer that question. Love the next question. How can we help get more research done in this area? Volunteer, volunteer, and volunteer. You know, that's all I can say. And I have to say that my patients are amazing. How can I say it? We beg, well, we don't beg. We don't even need to beg. We always ask patients, would you volunteer for this research? Would you volunteer? And I have to say that the rate of patients that are happy to help is almost 90% of my practice. It's the exception that a patient will say, no, thank you. I think that we are all, and you as patients more than, or as much as I do, desperate to find answers here and understand better. I think that so talk to your doctors, ask them what they're doing. If any foundation is collecting money for answers, just remember that NIH and a lot of the national federal foundations don't invest a lot of money in these areas, They invested in more cancer and diabetes and things like that. So donating to foundations that then can provide grants to do research is always a good area to help in research. Any association between hypermobility, EDS, and fat malabsorption? Not that I'm aware. And when we wrote the the chapter that we wrote for the American Journal of for the genetics through the EDS, I don't recall anything coming up that we had a clear objective evidence. Okay. Next question is, did I understand you correctly? Did the study show that POTS is not more common in the hypermobility community compared with the non-hypermobility? Yes, you understood correctly, but that is in my study, okay? So I presented our data, but I also presented national data from other groups that shows that there is difference between the POTS in the hypermobility versus the POTS in the non-hypermobility. Next question is about the association of hypermobility and IBS. IBS is a functional disorder. We don't understand the pathophysiology of IBS. I think that, and the question is, do we need counseling, just counseling? I will disagree with that statement. I think that counseling is always useful in the way I always put it to my patients, and not just with IBS, but this chronic overlapping pain condition, is that we can't separate our emotions from our body. If somebody that is chronically ill is not depressed or upset, I don't believe it, because I would be. But that is not the cause of the disorder. So I think it's good to do counseling to cope with chronic illness, but that is not because the disorder is in your brain. Or, sorry, I should rephrase that. That is not because this is a psychological disorder. We do think that a lot of this chronic pain that happens in patients with EDS, in patients with POTS, in patients with chronic overlapping pain conditions are managed by the brain, but not psychologically. And that's why when I talk to my patients, I separate very, very clearly what is psychological, what is brain. When I talk about the brain, I'm talking about your connections in the brain. And sometimes cognitive behavioral therapy can help rewire the brain. What happens in a lot of patients like this is that the brain is in a hypervigilant situation. We do know that a lot of patients with chronic pain have decreased vagal tone, which is your protective autonomic tone, and the sympathetic tone is probably in proportion increase. So we need to change that balance. We need to get the vagal tone to go up and the sympathetic tone to go down. In cognitive behavioral therapy, exercise, yoga, those all help you rebalance that vagal tone. So if you can find somebody that that does cognitive behavioral therapy, that may be very good. Why do you think a doctor will believe that that person or that patient still only needs counseling? Because I think that there is a lot of misconception in the medical system. If we do studies and we don't find anything abnormal, it's in the patient's head, because we doctors are trained that we are always right. So I think that we need education. I think that we need to educate our doctors, our primary care, and you as patients can educate your primary care to say, you know what, there is more data than this, you know, this is not psychological. But I think that that's sometimes the easy way when we don't have the answer. How to treat dumping. Usually we treat dumping by giving small meals very often, and we do the opposite of delayed gastric emptying. In delayed gastric emptying, we tell you no high fiber, no fatty meals. When you want to treat the dumping, you do the opposite. Take high fiber meals, take fatty meals, anything that per se would So does a patient with EDS type 3 needs to see a cardiology? In this case, they're talking about of GI symptoms and early satiety. I think that if it's not bad to see cardiology at least once with somebody with hypermobility EDS, just to get a good measurement of the aortic root, and then decide with cardiology if any follow-up with echo needs to be done in the future. So at least at some point it's important to see them. Do we treat pain, and I'm generalizing the question, without using non-steroidals or narcotics? There are a lot of medications available in the market that are used for chronic pain and fibromyalgia, like pregabalin or gabapentin, which work great for the chronic joint pains and the aches and pains and the fibromyalgia. Exercise is crucial. And I know that many times when we have EDS, we say, but I get injured or my joints hurt. But the only way we can protect our joints is by strengthening the muscles around the joints. The data in chronic pain shows that when we do less activities, the more we are inactive, the more the pain increases. So I think that we need to get out of the idea that having hypermobility is a contraindication for exercise. You may need to modify the exercise you need to do. You probably need to work with a physical therapist that would tell you, okay, if you do this, you may dislocate or subluxate, but do this and this. And what I find with some of our physical therapists in our community is that through using different gadgets like braces or vests or this and that, are able to stabilize a little bit the joints to allow the patients to exercise. But I think that there are a lot of alternatives without narcotics and without non-steroidals. And sometimes looking for a chronic pain group is a very good idea if your rheumatologist is not doing it. Can you have normal gastric emptying, delay small bowel motility, and rapid colonic transit? I don't know. I suppose that in the theory it's possible, but I'm trying to figure out the mechanism. Usually when the GI tract shuts down, it shuts down, and it's not acting in 3 different ways in 3 different parts. So I would think that that is unlikely. I think that that would be a very good question when Dr. Sood and Dr. Kovacic give a talk at the next symposium. Do we know the prevalence of cytochrome P450? And I don't know if this is directly to the general population or EDS. I don't think that we have any idea in the EDS, but I think that most of us physicians are starting to look at that. For so long, and now my answer is going to be more to this all chronic overlapping pain conditions, we had so many patients saying, I reacted poorly to this medication, I reacted poorly to this medication, and we had no understanding. And I think that now we are starting to understand that some patients metabolize the drug slower, or they're not responding because they metabolize them so fast that they don't even achieve enough blood level to produce the response. Do I see people with EDS that tend to be on the overweight side despite not eating a lot? Yeah. Yeah, and I'm going to change a little bit my answer. I see a lot of my patients with chronic overlapping pain conditions, with or without EDS, that tell me, you know, I don't eat that much, but I'm only gaining weight. Yes, I do, and I don't have a clear explanation. I have some ideas about it, some theories. One, I think that not necessarily they are very active. I also think that when nausea plays a role, people tend to gravitate towards carbohydrates because I think that carbohydrates are better tolerated when you are very nauseous. But yes, I do see it, but I'm not sure that I understand the pathophysiology of that. Do I know some group of doctors that treat mast cell issues associated with GI issues? I don't know. I know that Mayo has been very in tune with that, and they have people that specialize in mast cells. I think that there is in the autonomic groups, there are more. Sorry, I'm talking about pediatrics. The pediatric autonomic groups are being more in tune now with mast cell activation. And I'm going to just give some examples of centers. I think that if you would go to Children's Hospitals of Philadelphia, you go to Mayo, you go to Lurie Hospital in Chicago, Cincinnati, you may have groups of people that are doing this more. And I'm sure that I'm missing groups, and I apologize to my colleagues if I'm not mentioning them today. But I think that is still a very, very gray area in the PIDS GI group. I think that in many ways, PIDS GI is running very behind in the knowledge of hypermobility, in the knowledge of the comorbidities that come with functional gastrointestinal disorders, in the migraines, the fibromyalgia, the postural tachycardia. I think that my experience with most of the PIDS GI community, at the difference of the adult GIs, that there are centers that are looking more at all these chronic overlapping conditions, is that PIDS GI has limited themselves to the mouth to the anus rather than to the entire body. I'm going to confess my ignorance. Having medication stored in plastic tube could just contribute to mast cell and EDS. I really don't know. Any study showing connection of EDS, polycystic ovarian symptoms, and other hormonal issues? I am not aware. But I did not look at the literature ever from the GYN point of view, so I can't tell you that. Okay. Patient, and I assume that has EDS too, POTS, and gets severe stomach pain and diarrhea. And obviously must have nausea because takes Ativan to control the nausea. It seems that he's lactose intolerant and is missing a starch enzyme. So I don't know if that's sucrose isomaltase or one of those. So I think that part of the thing, if it's missing one of the starch enzymes, and I'm saying this in quotes, I think that working with a dietitian may help. With the stomach ache, the nausea and the diarrhea, sometimes trying a tricyclic antidepressant may be useful because the anticholinergic effect of the tricyclic may slow down a little bit the GI tract, as well as helping. We know that tricyclic antidepressants increase your pain threshold. That means that you have to have more pain to perceive the pain. So I think that that's something that you should discuss with your doctor. Somebody asked me if I used to be in Cleveland. Yes, only for 22 years. Rectal prolapse in a 5-year-old with EDS. And I would assume that other things were ruled out. Cystic fibrosis. I think that the first thing is always try to keep the stools very loose, limit the sitting in the toilet. The more we sit and push, the more we are going to prolapse. Use a step to help stool better. When everything fails, but I would say when everything fails, then it's worth it maybe a surgical consult. So this must be an adult person asking a question with EDS, POTS, dysautonomia, chronic constipation that seems to have so much pain and can't exercise too much. So the question comes here, sometimes when the constipation gets to be to a point that it's failing all the medical treatment, it's important to see a motility specialist to do a motility study. Sometimes it is that the entire colon is not working, and then the question is, do we keep the colon? Do we don't keep the colon? Sometimes using a cecostomy, which means putting a tube in the cecum and doing flushes with enemas from the cecum down towards the rectum can help. I also see in the list of medication that this person is using that there are a lot of new constipation medications like Amitisa and lubiprostone and Linzess, and again, I'm using commercial names. I apologize for that, but that have not been tried. So I think it's important to go and see a motility specialist, see if other medications need to be tried, and see if there is a motility disorder contributing to the constipation, and what is the next step that is needed to manage the constipation. Does weather and seasonal changes affect pain and fatigue and GI symptoms? Yes, patients will tell me that. Do I have a good scientific explanation? No. But I'm sure that there's something that we don't understand yet. Whom do you suggest to evaluate POTS dysautonomia? Cardiology, neurology? And the complaint is that everybody has 4 to 12 months waiting time. Yes, it's true. I think that whoever is in your area that is a specialist, sometimes it's run by cardiologists, sometimes it's run by neurologists. I think that having a GI autonomic like I am is the exception to the rule. Yes, there is a big waiting list. I don't have a special, I think that either one, cardiology or neurologist, is going to be the same. Neurology would probably have a little bit more knowledge in the management of chronic pain. But then you have a person like Blair Graff that handles and treats everybody and does an amazing job. So I think that you just need to figure out who is the best person in your area. Do I think that exercise helps with functional GI disorder? Yes, 100%. But I want to say something, my disclaimer. It takes 12 to 14 weeks to start getting the benefits from exercise. First, you're going to feel worse. And you're going to want to quit. Don't do that. The other thing is pacing. If you start exercising and you haven't done anything and you said, I'm just going to be a good girl and I'm just going to go to the gym for half an hour, let me tell you, you're not going to exercise for the next 2 weeks. You're going to ache, you're going to be exhausted, you're going to trigger a migraine, you're not going to be able to do it. When I recommend exercise, it has to be depends on what your comorbidities are, but it has to start very slow. And if 5 minutes is all the endurance you have, then you do 5 minutes every day. The key issue is that every day you can exercise, or at least, I say every day, knowing that we all skip 1 or 2 days per week. But I think that 5 days a week is the minimum. There are no more excuses below 5 days a week. So see what the threshold of exercise is. If you have joint issues, see what exercise doesn't hurt your joints. Maybe biking doesn't, but in the treadmill, you get a lot of hip pain, or you start rolling your ankles. So you need to find that exercise that is good for you. Water is always good on the joints. In doing a water aerobic class that is gentle, or doing a water Zumba class is a good way of starting back to exercise. So you do whatever amount, 5 minutes a day for the first week, then the next week you do 7 minutes, and then you do 9 minutes, and you slowly build it up until you are getting to half an hour to 45 minutes every day. It's important also to add some core exercises. We need to stabilize our core, our abs, our back, but the aerobic exercises are really needed. And you're going to see that after you exercise and you pass those 12 to 14 weeks, I don't want to lie to anybody, the fatigue starts improvement, the chronic pain starts improvement, the migraines decrease. But you need to be progressive, pacing yourself, and patient with yourself. The other thing that is crucial, and now I'm talking more about like a pod specialist than an EDS specialist, but many acute illness, even a virus, will exacerbate all the symptoms. And in these disorders, you can't have mercy on yourself or on your son or on your daughter. You need to apply tough love. So if you get an illness and you have a fever, sure, stay in bed for a day or two. On day 3, you need to get up from bed. You need to get back to the gym. You may not have the endurance that you had before the illness, but you need to start moving again. If not, very soon, you are going to lose all the ground that you have gained. So the next question here is, again, the association of fat malabsorption and EDS, hypermobile. I don't know if there is an association, but it's very easy to check for fat malabsorption, from doing a stool collection for fat to looking at the pancreatic function by checking a stool elastase. So I think that if that's what GI thinks that is related, I think that you should ask them to do studies to document the fat malabsorption. We don't know why weight loss produces orthostatic intolerance, but we know that it has been very well described in anorexia, so it could be related to that. So I think it's important when there is orthostatic intolerance that has developed with weight loss, that you get back to the gym, after, obviously with your clearance of your doctor, and to start working on getting retoned and get the aerobic activities. Medications for nausea. We don't have good medications for nausea. From the realm of medications, I do like cyproheptadine. Cyproheptadine tends to increase appetite and increase weight gain. Be careful. I've seen girls, teenagers gain 20 pounds in a month, and they're usually not very happy with me. There are some over-the-counter things that may help, like peppermint oil, ginger, that are worth it to try. I find that acupuncture in the ear many times helps with nausea. I don't know the good technical terms, but those wristbands that go into the nausea, a pressure point in the wrist, sometimes help too. So when it comes to the treatment of nausea, I throw everything on my patients. Go and do cognitive behavioral therapy, get acupuncture, get those little rings that they put in the ear that goes into the pressure points, get the rings get the pressure points in the wrist and see if that helps you. Try the ciprofloxacin, depends on the weight. Be careful because it can do a lot of damage. Now, if somebody has nausea and has been losing weight, ciprofloxacin is a fantastic medication. I do get complaints sometimes of patients with the ciprofloxacin that say, you know, Gisela, great, I'm really hungry, but it didn't touch my nausea, so now I really feel worse because I'm dying to eat, but I can't. Somebody is asking about PTSD as a comorbidity of this diagnosis. You know, I am going to answer this. My other hat, and a lot of my research with my husband and where we get the funding is in pelvic pain and interstitial cystitis and in myofascial pelvic pain. And we have a paper ready to go out that shows that if you have PTSD, you have many more comorbidities. And you know, PTSD is an interesting thing because, and I don't think that PTSD is necessarily associated with hypermobility. I think that PTSD puts us at risk of more comorbidities. And again, I don't want to say that this is the cause, but I think it puts us at risk of more comorbidities. And if we looked at the data from Drossman in irritable bowel syndrome in adult females, he finds that a lot of women with IBS have a history of abuse. So we know that there are certain triggers or predisposing factors that contribute to these chronic overlapping pain conditions. So if there is PTSD, I would try to any association between hypermobility, EDS, and CVS, and cyclic vomiting syndrome, not that has been reported. Not that has been reported. Could it be? It could be. I just think that we need to look into that. And gives me ideas of things that we do need to look into. So is there an umbrella organization to find motility docs or neurogastroenterologists near us? I think that I would look in Pediatric in the NASPGHAN NSPGHN website, that's for pediatrics. And maybe look in the American Gastroenterology Association for the adult people. Is diverticulosis a functional GI disorder? No. Diverticulosis, you are making packets in the wall of the colon, and then they can get infected. No, that's not a functional. There is a question here relating diarrhea, sometimes some constipation, nausea, vomiting, severe pain. I assume it's belly pain. And it seems that endoscopy showed a poorly formed granuloma, has a diagnosis of hypermobility, POTS, MCAT, IBS. And malnutrition and frequent admissions. I would revisit that poorly formed granuloma. Are we missing a Crohn's disease there? I will go back to the GI doc and say, do we need to revisit, just to be sure. Have I seen many cases of medium arcuate ligament syndrome or moles for people? No. And you probably hear my hesitation. I'm going to confess that I'm not sure that I'm an 100% believer in moles, so take my answer with a grain of salt. I look when I think that the picture fits the pattern of moles, but remember that 4% of the population has moles as a normal finding. So I always worried to order the test, find it, and send somebody to the OR for an incidental finding. So it really has to follow the pattern of the symptoms of moles. If you have chronic symptoms all the time unrelated to eating and they find moles, it may not be related, so be careful. Do we test siblings routinely? Do we treat siblings? You know, only if they have symptoms, I would do it. If they don't have symptoms, I would not. If somebody says, you know, my kid is super flexible, but she has no symptoms, I would say, keep her active, keep her exercising, be careful with injuries. But I think the worst thing we can do is to stop doing activities. Then we probably will develop symptoms. I think I come to the end of questions.
Oh, wow. You did a fabulous job getting through all those. Thank you so much. Everybody here that's live, attending live is really appreciative. We so appreciate you coming in, doing this presentation for us. It's been a much needed topic for us, and just thank you from the bottom of our heart here. Everybody that's attending live is thanking you on the chat now. We always welcome you back if you'd like to come back for any other topics or any other studies that you've done, and wondered if you had any closing comments before we ended the meeting for today.
I think that my closing comments is, you know, you patients sometimes know things ahead of us, doctors. So don't let people let you think that you're crazy. Pursue what you think is important. And I know you're going to get, how can I say it? Sometimes find a wall in doctors or make you feel that, that you're wrong, that you don't know anything. But it takes us time to say, interestingly, so-and-so said that, so-and-so said that, maybe this patient said that too, maybe there is something there. So be patient with us. We are learning from you, and we are truly learning from you. And what I tell you today may change in 5 years, but we are trying to learn from the things that you explain to us. And we appreciate when you volunteer, like somebody was saying, for research, because we are learning. We know very little.
Well, in your compassion and your willingness to work with the patient and help us through that and, you know, learn together is so clear. And we really appreciate you so much for that.
Thank you, Diana.
I'm going to go ahead and close the meeting out. Wanted to thank Dr. Chelimsky again for all of her time and all the work that she's done in the EDS community. And I wanted to remind everyone that we do have another presentation coming up on June 20th, and that will also be at 7:30 p.m. Eastern Daylight Time. And that's with her colleagues, Dr. Sood and Dr. Kovacic. So please join us again this month for that, and you can get further information on our website at edsawareness.com by clicking on the webinars tab on the menu at the top of the website. And also wanted to remind everyone that we are a nonprofit organization, and we are funded by your generous donations as well as by the store that we have associated with our organization, and that is bodysupportstore.com. So do feel free to go and take a look at the products that we offer there, and those proceeds will go to help us fund these programs. Again, I wanted to thank the doctor and thank you for all the live attendees for all your tremendous questions. Very good questions that you've asked her tonight. And this will be recorded and offered on our site in a couple of days. So I'm going to go ahead and close the meeting out, and good night to all the live attendees, and we hope to see you for our next presentation. Thanks again, Doctor, and
thank you, everybody, and thank you, Diana, for working on this so hard.
It's our pleasure. Our pleasure. Have a good night, everyone, and we'll see you next time. Bye-bye.